This week we are going to revisit the concept of informed consent. Like before, we're going to start with Beecham and Childress. We're going to just review their framework of informed consent, and then we're going to look at an example of disclosure, so it relates to Cohen's article, and then we're going to look at a pelvic exam example that's actually from Beecham and Childress with respect to Kingma's article. Hopefully this looks familiar, since we devoted a whole lecture to Beecham and Childress' framework on informed consent. Just as a refresher though, the first threshold elements are sort of the basic minimum expectation to ensure that patients can have competence and that their actions can be voluntary. And so if those are not met, then the patient is incompetent, and the rest of these different sets of criteria are not necessarily applicable. But if a patient does meet these threshold elements, then the next step is communication of information. And so these information elements include disclosure, recommendation, and understanding. We focused on disclosure and understanding in our discussions previously. And then the final part of informed consent is an authorization or a refusal. And so that's where we get the decision versus, the decision in favor of one plan or in refusing one plan, and then the authorization of it. Cohen's article is going to deal with disclosure, and ultimately the question is going to be something to the effect of, is it justifiable to withhold certain information if it's going to benefit the patient? And Beecham and Childress gave us an argument to the sort of same effect here a little bit, but I thought this would be an interesting article to discuss and look at the matter a little bit more deeply. So before getting into it, let's look at an example. Imagine that there's a physician who comes in who is about ready to administer some sort of medicine to this patient, and they're just trying to make sure that they disclose all the relevant information, and part of that information is that the medicine might cause hand twitching. And so once the sort of medicine has started to be administered, you get like 10 minutes later, and then the patient's like screaming for the doctor or hitting the call button and concerned that now their hand is twitching and that they're experiencing this side effect, when in reality the hand twitching doesn't actually happen unless you use the medicine for a prolonged period. So imagine like it doesn't usually start to occur until weeks or months afterwards when there's a buildup in the system. So this is a situation in which a patient might have anxiety, or they might actually induce the negative symptom just by hearing about it. And so the question is it always in the best interest of the patient to disclose all the information about a treatment? That's going to be the question that's motivating Cohen's article. Cohen's article is about this nocebo effect. So the nocebo effect is the expectation of a negative outcome precipitated by just sort of hearing that it is one of the possible outcomes associated with a certain treatment. And so just like with our example in the previous slide, the idea is that the patient hears that hand shaking is going to be one of the possible symptoms or effects of the medicine, and so by knowing about it, it ultimately causes it to happen. And if you remember from our reading in Beecham and Childress earlier, this example case about the Navajo not wanting to hear about the potential bad outcomes of a treatment because they think that if you talk about it, then it speaks it into existence. That's sort of the same thing that's going on here. The nocebo effect is this psychological phenomenon where a patient makes or manifests the bad or negative effects of a treatment just by knowing about them. So the nocebo effect is the flip side of the placebo effect. I imagine that you've probably heard of placebos before, right? Placebos are medicine that actually are inert, that they have no therapeutic value, but they're given to a patient because then it feels like something's being done, and it causes this psychological response to think that you're getting better even though you're not really receiving anything for it. So the nocebo effect is the opposite of that. I think one of the interesting concepts that get brought up here, because Cohen gives us a couple of examples, aspirin case and the Parkinson's disease case. I won't necessarily go through those right here. You can look at them for yourself. But the idea is that the nocebo effect causes harm for the patient. It brings on this, it could bring on very real psychosomatic symptoms, but at the same time, it just generally causes harm for the patient, creates anxiety and issues like that. And so it's not necessarily what the patient wants. And so this idea of ironic autonomy I thought was really interesting, which is the idea that there are cases where a manipulation such as non-disclosure of information, which would otherwise compromise patient autonomy, is in a given context necessary to uphold her autonomy. To unpack that, the idea is that to ensure that the patient retains autonomy, you have to withhold certain information that might otherwise be considered necessary to make an autonomous decision. So if a piece of information is going to cause harm and put the patient in a certain mental state that then compromises their autonomy, there seems to be a case to be made for withholding that information for the sake of autonomy. That's what makes it ironic, which I thought was really interesting, and thought that it was a really good concept in play here. And then Cohen goes on to give us this principle of extendable information. And this is to counteract the idea that you can always leave out or don't disclose certain information to a patient because you think that it is not conducive to positive outcomes. And so this principle, though, is whenever extra information is requested, it ought to be provided. So think about those sort of drug commercials where they list all the different side effects that are associated with a particular treatment or a particular medicine. And most of the things that get rattled off you may not even be familiar with, but they're obligated to provide that information. In this situation, with the nocebo effect, and what Cohen is suggesting is that you might be allowed to withhold certain information if you think that it's in the best interest of the patient, because it's actually going to cause them harm if it's revealed to them. The principle of extendable information, though, is that if a patient requests that information, you are obligated to still provide it to them, regardless of what you think might be best in that situation. So Cohen says that this principle must always be operative. Lastly, I think let's just talk about Cohen's argument more generally. And it's this idea that the greater the harm of the nocebo effect, the weaker the obligation to disclose. So the caregiver is allowed more leeway in judging the limits of disclosure in ways that preserve trust. So if there's a connection between the physician or the healthcare provider and the patient, trust is an essential part here, and we ultimately seek this optimal balance between respect for autonomy and care for the patient's well-being in the practice of informed consent. But the nocebo effect also impels us to question how to disclose information. And so this potential for the nocebo effect creates a straightforward moral duty to use the formulation that causes fewer side effects. Overall, like I said, I really enjoyed this article, and I hope that you did too. But it provides a window into a situation where non-disclosure isn't necessarily unjustifiable in certain instances, and I think for that it's a worthwhile consideration. If you look at Kima's article, I want to return to this example of pelvic exams being performed on anesthetized patients in teaching hospitals. So in Beecham and Childress, there is this case that I sort of skipped over because I knew that I was going to return to it later in the semester. But now let's just sort of look at it. I'm reading from the chapter on the principle of respect for beneficence here. It's on pages 111, 112 in my book. So the case begins with, for instance, many teaching hospitals have allowed 1 or 2 medical students to participate in the examination of women who are under anesthesia in preparation for surgery. Anesthetized patients have been considered ideal for teaching medical students how to perform a pelvic exam because the patients are relaxed and would not feel any mistakes. And when questioned about this practice, some directors of obstetrics, there we go, and gynecology programs have appealed to the patient's general consent upon entering a teaching hospital. Such consent typically authorizes medical students and residents to participate in patients' care for teaching and learning purposes. However, it is not specific as to which procedures might involve participation by medical students. And so the idea here is that within a teaching hospital, the whole idea is that a lot of different medical students are learning how to perform different procedures and things like that. And so since you as a patient chose a teaching hospital, the thought is that you consent blanketly to these different procedures. And so the question is, a patient who is under anesthesia, who may not have been given full information about what was going to happen, is this a case in which somebody's autonomy is violated in a certain way? And I think if you're like me, when I was reading this, I found it a little bit, let's say, viscerally concerning, insofar as, like, just because you decide to go to a teaching hospital, does that mean that I consent to everything that could be done on me so then medical students can learn? I mean, I understand the basic premise of a teaching hospital, but at the same time, it seems like pelvic exams are pretty intrusional, I guess, to put it mildly. In here, in the Beecham and Childress reading, they talk about how although pelvic exams are not invasive or particularly risky by comparison to surgery, patients may object to the intrusion into their bodies, especially for education and training. Some women readily consent to the participation of medical students in such examinations, but others view the practice as a violation of their dignity and privacy. One commentator appropriately states that the patient must be treated as the student's teacher, not as a training tool. So, like I said, I skipped over this before, but when hopefully you came across it, you thought this seems a little concerning. And that sort of initial take is what Kingma is going to be responding to in this next article, is this idea about women and having this sort of asymmetrical relationship or expectation in medicine, especially if they are, especially in relationship to OBGYN and stuff like that. What I really appreciate most about Kingma's article is the sort of realization that our views of autonomy and consent might shift based on the type of patient that we're dealing with and the type of treatment that we're providing. And so Kingma's article is sort of attacking this, our sort of preconceived notions about mothers in the setting of maternity care. She talks about how, excuse me, ethical analysis provides at least 2 independent grounds for demanding more stringent requirements on informed consent and respect for autonomous decision-making in obstetrics. The first one is that obstetrics messes with particularly socially complicated body parts, which leaves no room for carelessness in respecting autonomy and requires checking for genuine consent. The second part being, most maternity care has a deeply altruistic character, which is more comparable with organ donation and non-therapeutic medical research than with ordinary medicine. However, if anything, consent and autonomy are less well respected in maternity care than elsewhere in medicine, and even frequently under threat, which leads to this paradox of autonomy and consent. The idea that in maternity care, autonomy and consent should be at the forefront or a priority, yet they are treated as secondary in a lot of contexts. And so, what Kingma wants to do is talk about why this paradox of autonomy and consent exists and what could be bringing it about. So, we get 4 different possibilities. Well, not necessarily possibilities, they're all sort of interconnected here. So, the first one is that being pregnant and giving birth are sex phenomena that are deeply gendered women or woman. And so the idea is that a woman is the one who gives birth and a woman is the one who is pregnant. Then there are these gendered social expectations that demand a woman be particularly submissive, passive, non-assertive, and at the service of others, and that women invite potentially violent punishment if they do not actually comply with these expectations. So a woman, and especially a future mother, is always expected to be self-sacrificing. These are just the way in which social norms have been constructed, and it's obviously a threat to the woman being able to make autonomous decisions and consent to certain things on their own behalf if they're always expected to be self-sacrificing. Then the idea is that women's bodies are perceived as available, potentially primarily as objects for the use of others who may transgress these bodily boundaries at will, or at least face relatively lenient penalties if they ultimately do. So here again, it's the way in which women's bodies are perceived within the social sphere that creates this paradox of autonomy and consent. So just to make sure that we're all clear here, Kingma is not trying to say that these social norms are acceptable. She's just trying to point out what is leading to this paradox of autonomy and consent, and it's typically these social norms. And finally, women are considered less rational than men in a lot of circles. And as Kingma ties all of these together, she says all of these expectations may be amplified in childbirth, when women are deemed especially lacking in rationality and when they enter the state of motherhood, in which gendered norms and expectations of maternal sacrifice are near limitless and highly dichotomous. There are only perfect mothers and dreadful ones. So these expectations that are that surround gender norms and social norms, they can infringe on a woman's ability to make autonomous decisions, and they also complicate patient interactions with physicians who think that their first responsibility is to ensure the well-being of the child or the fetus, and that they should be allowed to do whatever they want to the woman to ensure that the interests of the child or the fetus is taken care of. And so Kingma is going to argue, that just because a woman is going to have a baby doesn't necessarily mean that their autonomy and consent can be undermined. So as Kingma says, baby interests or baby having interests per se cannot undermine the importance of autonomy and consent. An argument on behalf of the baby requires significant extra steps. It needs to be shown that the mother has some special obligation to the baby, an obligation to undergo significant risk of harm, to remove a risk of harm to the baby. So it first has to be shown that one set of harms is prioritized over another. That's not necessarily the case. It's just the expectation that's thrust upon women in these circumstances. So needing an argument to justify why causing harm to one person is okay if it alleviates the harm of another person. The next thing that an argument would have to do is it needs to be shown that the medical profession is legitimately in the position to promote or even enforce this obligation through measures that insufficiently respect autonomy or consent. So why would a healthcare professional have the authorization to decide whose harms are prioritized and whose are not? And I think Kingma is right to point out that it's not clear that medical professionals should have the authority to make that decision. And then here at the end, an argument would also need to show that both the extent of the supposed special obligations and the justification for medicines legitimately being in a position to promote or enforce them outweigh not just ordinary requirements to respect autonomy and informed consent in medical encounters, but also the independent reasons noted in this article for why these requirements should be more stringent in maternity care. So there would have to be some argument for why they aren't more stringent in maternity care as they are in other parts of medicine. And I think Kingma lands on this, which is that nobody considers that these arguments, if they can be made, should be evaluated in the light of prima facie increased need for respective autonomy or consent in maternity care, meaning that no matter how you would respond to these issues or what an argument might be tried to give for why a woman's interest might be subverted in terms of like their ability to make autonomous decisions, and that physicians or healthcare providers obtain consent in the first place, it doesn't even violate this idea that it seems to be the case that respect for autonomy and ensuring genuine consent in maternity care is a necessary requirement for the expectations within bioethics, that it's just an obligation. So in total, just recapping a lot of what I just said, this doesn't necessarily cover everything in the article, but there's this idea that there are these gender norms and social norms thrust on women, and those norms ultimately give people, I would say, false justification that women's autonomy and their consent are less important than other concerns within maternity care. And I think Kingma is right to point out that it seems wrong to say that respect for autonomy and consent change when certain people are in certain circumstances, especially when those circumstances cannot be controlled. And so I think where I want to finish this long discussion is that why I like this paper again is it shows you a window into how autonomy and consent can be misconstrued or construed in different ways within different contexts. And it's important to make sure that there's some sort of grounding for this obtaining autonomy and consent, which I think if Beecham and Childress were to chime in here, they would say it's patient's best interests. And if we're always thinking about the patient's best interests, then we need to provide some sort of argument about why violating somebody's autonomy, or they probably wouldn't say anything about, they would probably be more concerned with the principle of respect for autonomy here because it's tied to consent. But there would have to be a good argument that uses moral norms rather than gender norms and social norms. We're looking for moral norms because this is a moral argument to justify the overriding of a person or a woman's autonomy. And it's not evidently clear that in maternity care that the default should be that women's autonomy and consent are undermined. Now let's recap. So we started by looking at the nocebo effect in Cohen's paper. The idea here is that the nocebo effect is a situation in which you present information or you disclose information to a patient about the negative effects or symptoms, and that disclosure ultimately induces those symptoms or negative effects. And the question is it permissible to not disclose the information that might ultimately harm a patient in these cases? And so Cohen argues that the nocebo effect gives us a responsibility to withhold information in cases which it would cause patient harm. This is pretty consistent with what we saw in Beecham and Childress' readings as well. The idea that it's not an obligation to present all information, but it's to present the information that allows a patient to make a informed decision. Now, I'm not trying to say that you should always withhold information from different patients that you would encounter, but remember, we're looking for good moral arguments to justify different practices like this, and the nocebo effect is just one case. The second reading that we talked about was Kingma's, and so the idea here is that it seems like obstetrics is a medical field where autonomy and consent are like paramount, they're extremely important, yet they are both routinely overridden. So there are certain gender and social norms that are thrust upon women to act in a certain way, or it's just implied that they accept different risks or harms by default. And Kingma is wanting to argue that even if a woman desires to do everything to benefit their unborn child, that does not necessarily mean that they forfeit the right to autonomy via consent. And I think that's a pretty modest argument based on everything that she presents. And again, the choice for this article was to sort of familiarize you with this idea that autonomy and consent may be, or at least our perceptions of autonomy and consent might be affected by the certain contexts that we find ourselves in. And it's to be mindful of the fact that here what we're looking for are quality moral arguments to act in such a way that might infringe on a patient's autonomy. And what Kingma's article is sort of showing here is that social and gender norms are not moral norms. Hopefully you remember that from our Vaughan reading, and that we need these moral norms and moral reasons to ultimately make decisions like what happened in maternity care that violate a patient's autonomy and sort of skirt this pursuit of genuine consent. So that's why I picked that article. I picked the other nocebo article just to give you a window into another reason which autonomy may not always be straightforwardly upheld by providing more and more information. So together, I thought that these provide a pretty good sort of sample of what could be talked about in the informed consent literature.